very pleased to welcome you today to our consortium meeting on the 2nd of December, actually one day before the International Day of Persons with Disabilities, which is the famous 3rd of December, on our GRACE project. So the last meeting, the last consortium meeting we had was in March 2021 at the launch, and now we are at the end of our 2nd year, so a lot of things have happened meanwhile, and this is why we would like to update you on that, and also discuss exchange with you and discuss also the last year that is still ahead of us. So I'm Cornelia Barrett. Nell, most people know me, and I will guide you through today's sessions. I will do the first part with a briefing on GRACE and on our research approach, and then we will travel to the field and hear from our field teams what they've been doing and what they're planning to do in the last year. So you have received the agenda in the last mail, and as I said, I will do this first part and we'll have a break in the middle, and we'll have plenty of time in the end where we can exchange and discuss with you. This is why we invited you. Good. So before we dive into the project, we'll start with a little bit of history pre-GRACE, let's say. So basically the data analysis that has led to achieving that grant. And there was a study, which is also the first paper of my PhD, which I'm about to finalize, a huge retrospective data analysis of over 280,000 individual patient files. And these are rehabilitation users that access centers that are supported by the International Committee of the Red Cross Physical Rehabilitation Program. And it's a study across 14 countries. And what you can see on the data there, there's Ethiopia and Cambodia included, the 2 countries where we do field research now. What we can see here is this proportions of male and female, so more men than females are attending rehabilitation, and that is not new. This is something we, when you look at the ICRC annual reports of the physical rehabilitation program, this is a percentage that was obvious throughout the years, and the explanation for that was, it's clear these are data from conflict countries. Men are the ones who fight, the combatants. Men are those who step on landmines. The large majority of landmine victims, that's male, and this is why men need rehabilitation. However, we also have a large body of evidence that altogether women in low middle income countries are more likely to have a disability compared to men. And we also know that women and girls face massive access barriers to accessing health services. And this is more pronounced if this is in conflict countries or if women have disabilities, the famous intersectionality. So with this data analysis, we also managed to show that the explanation that men are more at risk of being injured and needing rehabilitation this hypothesis cannot be upheld, because what we did in the data analysis is data disaggregation, looking at age groups and looking at specific health conditions. And there we could see that in age groups that are unlikely to be directly affected by conflict, very young or very old, or also specific health conditions, we could see also a huge discrepancy. And I just bring one example, which is polio. So we know from global prevalence data that in terms of post-polio syndrome, it's roughly 2/3 of women who are affected. However, in our data, it's the opposite. It's those who are seeking rehabilitation services for polio, which is clearly not direct conflict consequence, we see 2/3 of men attending. So all of this data was actually preceding the project that we're doing now, and we managed to get this grant for GRACE. So that stands for Gender Aspects in Rehabilitation of Persons with Amputations in Conflict-Affected Environments. So we choose amputations as a health condition because the biggest number of people, at least in the ICSC database, were persons with amputations, and it's also an important health condition worldwide that requires long-term, lifelong follow-up. And so the Swedish Research Grant financed this project, and we are grateful to the Swedish taxpayers that allow us to carry out this research now. We have a number of partners in this project that is a mix of academic institutions, implementing partners from high-income countries, from low-middle-income countries, international partners, and the two partners in our field projects are Exceed for the Cambodia project and Wolaita Sodo University for the Ethiopia project. And now we are going to look at our core research team. I have distributed us geographically where we sit, and now I would like to give the floor to our team members to please present yourselves and also your role within GRACE. Just before we do that, all of you in the audience and the field teams, you will have a chance to introduce yourselves in the Q&A session at the end of our meeting. So if I can ask, please, Andreas, can you start and introduce yourself?
Well, hello, everyone. Thanks, Nell, so much for that very nice presentation of your research and the GRACE project. It's a pleasure for me to be on board here. And yes, I'm Andreas Vladis. I'm a surgeon by training, and I got to know Nell when I was the chief surgeon of ICRC in Geneva. And that's where we started thinking about starting this project, which has blossomed into something really fantastic and promising. So together with Cleona, I'm the principal investigator of this project. I will stop there. Thank you.
Thank you. Please, Cleona.
Yeah, good morning, good afternoon, good evening, everybody. My name is Cleona O'Sullivan. I'm Associate Professor here at University College Dublin in the School of Public Health, Physiotherapy and Sports Science. I'm delighted I'm a physiotherapist by background and met Nell through the global PT networks a number of years ago, and it is a real privilege for me to be a co-principal investigator on this project. And I just, thanks to everybody. We have a fantastic team of collaborators that have made this project work and continue to work really, really well. And it's fantastic to be here today. Thank you all.
Thank you, Cleona. So I'm next. For those who don't know me, I'm Cornelia Bard or Nell. I'm in Geneva, Switzerland. Based, and in this project I'm the overall research project manager, so coordinating between the field projects and PIs and overlooking the overall operations of this project. And we'll move on to Cambodia. Cicely, please.
Good afternoon from Cambodia. I'm Cicely, and I'm the project manager for Cambodia project. I'm a prosthetic analyst by background, and I'm overseeing the three Cambodian Physical Rehabilitation Center under the support of Exit and the Royal Government of Cambodia. I'm also the director of the Department of Prosthetic Analysis, where we train students to be prosthesis and orthosis from 27 different countries under the National Institute of Social Welfare of the Ministry of Social Welfare in Cambodia. So my role and responsibility in the project is to facilitate the Cambodian stakeholders as well as clients, and also supporting the research assistant for this project. Many of time we will be presenting the progress of the Cambodia project to you. Really nice to be in the meeting today and get to know everybody and to see the progress of the project and overall. Thank you.
Thank you, Cicely. And our last, our Ethiopia project manager, Fakadu, please, the floor is yours.
Thank you very much. Hello, everyone. I'm Fakadu Elias from Walaita Soda University, southern part of the Ethiopia. And it's a privilege to be a project manager for GRACE project of Ethiopia. And I'm the Dean of School of Public Health in Walaita Soda University and Assistant Professor of Public Health. And I'm very happy for working with dedicated members of this project. And thank you very much.
Thank you, Ricardo. Fantastic. So again, I think most people know me, but I should probably add that I'm a physiotherapist by profession, and I have spent many years, so almost 13 years in humanitarian services, most of these years for the ICRC and also for other actors. So this is also a bit of the background, how we get to do this research. Finally, great. So we will now move on to giving us a bit of a background to GRACE. So the GRACE project, a 3 years research project with 3 work packages and 3 objectives. We will look at the objectives 2 and 3 when we have the field team presentations, because this is the field work actually. But the work package 1, the objective 1, is a retrospective data analysis on sex differences in all various factors among service users with amputations attending ICRC supported rehabilitation centers across 5 countries. So this is the first part of this research project, and that has ended in a publication which I'll introduce in a while. So just generally what we've done so far, there was the publication from the first work package, the first year, a desk, so basically a research from the office desk. But we have in that time also formed research teams. We have now done a number of workshops and had trips. And here you can see a little collage of all these activities. I will not go into detail because that's what the Cambodian Ethiopia teams will talk about after. I will focus on this research, the retrospective data analysis, which here you can see the publication in the BMJ Open. You also have a QR code for open access to this article. And that study looked at 5 countries. They are in this ICRC database that we use. They are the countries with the most persons with amputations, including Cambodia. Ethiopia was not included in that data analysis because they didn't have a sufficient number of persons with amputations in that database. And it looked, you can see that it's actually a large number of people, over 28,000 persons. And we looked also in great detail in different amputation causes. We looked at amputation levels and combinations, etc., etc. I will limit myself here to a few of these sex differences. And overall, we see that it's 85% of the rehab users with amputations are male. And if you look at the traumatic group, here we have even higher male dominance, 89%, in the non-traumatic group, 73%. So these are the figures that we report in this study. In terms of interpretation, it is not easy to compare these figures because prevalence data from conflict contexts are not available when you want to look at amputation and gender. And we also know that these countries, so there's an acute conflict, there is a massive landmine contamination. And for instance, we know, as I said before, most of the landmine victims are male. And in this overall cohort, almost half of the overall cohort had a conflict-caused amputation, and over a third had a landmine-caused amputation. So it is not straightforward to say, well, this shows that there are this is not prevalent. Women with amputations are underrepresented. However, we had some hints, and one I want to point out here. It is the living environment, so the self-reported living environment of persons with amputations showed that if they come from an urban background, urban setting, women are significantly more likely to attend than if they come from a rural background. So urban is 19%, it's higher than the overall distribution of 15%, and rural is 13% female attendance. So these are hints that show us that there are certainly access barriers that need to be explored, because it is highly unlikely that women from urban settings are more likely to have an amputation, so that this reflects prevalence. However, this study confirms again that we need to go to the field and find out by talking to the people themselves. And in order to do this, the research approach we chose is community-based participatory research, CBPR. And that's a very interesting approach of qualitative research, because it has several, here you see several quotes from the literature on CBPR. So CBPR integrates education and social action because it has the goal to improve health and to reduce health disparities. We see a health disparity here, so it is the approach that was that seemed suited. And what was also very attractive to us was that CBPR equitably involves all partners in the process and recognizes the unique strengths that each brings, which means we wanted to have eye-level partnerships, and we wanted to have a research project where we consider the knowledge a community has equal to the knowledge and skills that experienced researchers have, because it is about co-learning, it's about a mutual benefit. And another interesting aspect is that the project doesn't, the partnership and the commitment doesn't end when the project ends, but it is really about driving change that continues after the project and the grant, the funding has ended. It's really also about sustainability and about finding solutions to address health inequities. Now, CBPR in the literature has 7 phases. We are now in phase 4 and 5. We are conducting research, we are discussing and interpreting findings. And the previous steps, if you look at the previous steps, forming a partnership, assessing the community, identifying priorities. So in order to do this, you need funding. And in order to get funding, you need a research objective. So in our case, we did have partnerships from previous collaborations, both with Cambodia and with Ethiopia, but we didn't have funding to do this community assessment and identification. So what we did in our project, we arrived with a research objective in the community, and we developed the project further now with the respective communities, with our field teams. And our next steps now are, next year we will still continue to collect data, to interpret findings, but also more and more focusing also on dissemination, translating research findings, and continuing that partnership to drive change. So what happens on a daily basis in our project? We have regular meetings online with all the different projects. We have research capacity building, and that includes all of us. We are collecting data, we are processing the data, and as we do that, we are continuously developing the research approach as well. And now is the time where we will, for those who are not yet in Cambodia, we'll hop on a virtual plane and hear directly from the field about their activities, challenges, achievements, and plans for the future. And I'm delighted to give the floor to Sopari, who will present the Cambodia project for us. Sopari, please.
So, can you see my slide? Okay, so good afternoon to guests and honors. So today is a great pleasure for me to do the presentation or sharing the progressions of the GRACE projects in Cambodia. So first of all, I would like to introduce myself, that I'm Supari. I'm the research assistant of the GRACE project that recruited by the GRACE project on March 2022. So the Cambodian team, so we have the lead researchers in Cambodia, that is Ms. Sisri Kane, that is the confederators of the Exit Worldwide, and Mr. Hieng Thirat, he is management team member in Exit Worldwide, and either myself, that is Supari Med, I'm a research assistant. Either I'm a PNO from my background.
Sorry, just very quickly, you are in presenter mode. Do you want to try once more to go into full slide mode? Like before, it did work before.
Yeah, so is it okay now?
It's still presenter mode on my screen. Yes, perfect. Great, Sopari. Please.
Okay, so good afternoon to all guests and honors. So today, for the next slide. It's okay for the next slide, right? So related to the study objective of this research is to understand the perspective of men and women with amputations who have and who have not attended the rehabilitations, about the different components of access, such as the physical accessibility, acceptability, affordability, and appropriateness, availabilities and perceptions of the rehabilitations in Cambodia. And either we also the studies objective of this research also to understand the perspective of the health workers and communities leaders on how the gender aspects impact the services and also the service deliveries and health outcome in Cambodia. So for the research study design, we also use a community-based participatory research approach, which is the researchers and the community's members collaborate as equal in the research process. So for the next slide related to the preparatory work. So we have the preparatory works as in the progress. So that we also had the CBPR workshop that was held on April 2022 in Cambodia through online. So it was a great honor that Mr. or Professor Anne Endes from Santes, Norway, he have done the presentation related to the process of the CBPR and plan to process the research, and also which participants will be the priorities in the research process. And also we all for the staff in Cambodia also have involved, and it's also the great time for us to build the local capacities in this training for the potential researchers in the data collection and data discussions. So related to the ethical approvals and the local research advisory committee. So as I am the research assistant, so I have translated and submitted of the ethics application materials to the National Ethics Committee for the Health Research in Cambodia. And they already have approved it. So for the local researchers advisory committee, we also held on June 2022. It also was discussing and give a feedback on the research question, participants, recruitment, and interview the questions. And for the next local research advisory committee meeting will be held on January 2023 in Cambodia. So related to one-to-one interview. So for the participant going to involve it for the interview, we also selected approximately 60 participants in total. So 5 women with amputations, which is the client who never used the prosthesis or never accessed the rehabilitation centers. And also 5 men with amputations, which the client who never used the prosthesis or never accessed the rehabilitation center either. So either we are going to do the interview on 15 men with amputations who have accessed the rehabilitation, and either they got amputations less than 5 years. And 15 women with amputation who have accessed the rehabilitation center. And also we are going to do the interview on the participant who work on the healthcare workers. It's about 20 healthcare workers, such as the physiotherapy, prosthetists and orthotists, nurse, CDPO. So we call that Cambodian Disabled Persons Organization staff, and also the community workers, doctors and surgeons. And also we also plan to complete all the transcripts that about 60 transcripts. So I'm going to talk related to the progress to date. So for that, the work that I'm doing right now is the data collection and field works. So I have interviewed 18 participants in total. So 2 prosthetists and orthotists, 1 female prosthetist and orthotist, and 1 male prosthetist and orthotist. And 1 client who never used the prosthesis at all. Actually, he has been to the rehabilitation centers, but due to his age, due to it was the wars in 1997, so that it's not a really big war, but only the problem in Cambodia, so that he also been to the rehabilitation centers. Unfortunately, that day it was the problem in Cambodia, so that's why he didn't get any devices from the rehabilitation centers. And also we have done with 11 men with amputations that he got amputation less than 5 years, and 4 women with amputations that they got amputation less than 5 years. And also I'm doing the data organization, like as the data transcription and translations. And I have completed 8 transcripts. And we also have online team meeting in every 2 weeks. So I'm going to talk about my challenge. So for the challenge, the main challenge for me is I'm going to find the men and women with an amputation that have never accessed the rehabilitation center. So this is the main challenge for me, because I have been working closely with the Cambodian disabled persons organization staff, that they work really closely at the field and contacting and sharing information about the rehab center to the client, either sharing the information about the client at the field to the organizations in Cambodia. And the other challenge is, this is the first time for me to do the transcription, because as my language is going to type in many words, and so that it also takes a time for me to type in Khmer language and translate to English. So this is the timeline. So the grant charts below, it summarizes the time plans is for the projects during the grant period, and so how the projects will be implemented. So talk about, you can see in the grant chart there. So the purple color, they talk about the study planning, application, and ethical approval and permissions. And the blue color talk about the recruits, research assistant, and translations of the ethics application material, application for the ethical approval, and permissions to establish the local research advisory committee. And the green ones is talk about the data collections and fieldwork and data organizations and data entry, either cleaning and data transcription and translations. So the orange color is talk about the data analysis and writing. So right now I am in the process of the green color ones and the orange color ones. Okay. So thank you very much for your attendance. So any question, and warmly welcome.
Thank you so much, Supari. I think that really wraps it up in a great way, and I think we also see what has been achieved and the difficulty. So really interesting, and the plans for the next year. I would say we save the questions to the end, unless someone has a very urgent question that cannot wait. But for anything that is about the project, I think it's better we wait, because then we can also have Ethiopia presentations and discuss both projects in the Q&A session at the end. Great. So we are very good in time now. What I suggest, I will just quickly share my screen once more where we are. And we are now getting to the break. So I suggested 10 minutes break. I mean, we're a bit ahead of time, but I would suggest we keep it like that. So it's 10:43 now. Let's make it 12 minutes, 10:55. So if we can be back just I'm talking about my time, but let's make it 5 to the next hour, 5 minutes before the next hour. And, you know, it's about physical activity. We are all rehabilitation specialists, so please don't forget to move during the break and not sit and maybe hydrate and go outside for a minute, and we'll meet back in 12 minutes. Thank you very much. So welcome back. I think most people are back. If you, yes, exactly. If you just quickly want to show your video, turn on the videos, that we're sure we have everyone back. Great. And so that we don't miss the Ethiopia part, because now I'm pleased to give the floor to my colleague Fekadu, who will take you through the Ethiopia project. So we're traveling to Africa now, and I'm looking forward to the presentation. Please, Fekadu.
Fekadu, you are on mute.
Sorry. Okay. Let me share it again. Okay. Thank you. Now I'm Kadu from Walaita Soda University, Ethiopia. I'm going to present the progress to date regarding the GRACE project Ethiopia. The first thing is the research team here in Ethiopia. We do have research assistants. The first picture shows the male research assistants, Bella and Baskadu, and other research assistants. Those recently joined the women research assistants, Suabolk and Tegnish. These are the research team in Ethiopia. And so the main objective of the study, as it has been mentioned in the previous presentation, is the same for Ethiopia as well. And it's just to understand the perspectives of men and women with amputation, those who already access the service, as well as who never have been accessed the rehabilitation service, about some components of the service, like access. It could be physical, again, accessibility, acceptability, affordability, appropriateness, availability, and the perceptions of rehabilitation in Ethiopian context. And we're also going to know the perspective of health workers and community leaders on how gender aspects impact the access of the service delivery. When we are saying service, it's about a rehabilitation service and the health outcomes in Ethiopia. So we use the same approach, that is a community-based participatory research approach. And we have tried to make it contextualized to Ethiopian context. So the activities so far that we have gone through are, main thing is the collaboration. As you know, the project has been started based on the previous partnerships that we had with UCD. So we have the project identified the research lead, then we try to submit the proposal to approval of IRB here in Walaita Soda University, Ethiopia. So we need to contextualize the proposal to the requirements of the university, and we try to do that, and we submit the proposal, then we have signed agreement, and we also identified the research assistants for 2 study areas. in our case, we do have a study in Arbaminch and in Walaita. Both are in southern part of Ethiopia, but a bit 120 kilometers apart. So we identified one research assistant from Arbaminch University, again, the woman as well from the Arbaminch University, and the other research assistants from Walaita Soda University. That's how we also ensure that we are adhering to the approach, that is CBPR, because we need to engage the local institutions, those universities and other stakeholders. Then we also have provide training for those research assistants. That's followed by the joint planning and workshop, another activity that has been done. So we have 2 rounds of workshop for Ethiopian cases. The first in Dublin, where I have been there, and there we have conducted the workshop, and that workshop really helped us, particularly in designing local research advisory group. Initially, we planned to have one local research advisory group, but on subsequent workshops and the brainstorming session that we had, I will present them later. We decided to have local research advisory committee in 2 areas, in Arbaminch and Walaita. And again, in the same workshop, we have been advised to make 2 groups for separate women and men local research advisory group. So we do have these groups, cohorts, like women local research advisory group in 2 sets, 2 areas, and another main local research advisory group in another area. So those workshops helped us to design the local research advisory group. And another workshop that we did in Walaita Soda University, hopefully Dr. Barakat and Dr. Mengistu are the workshop partners. They really helped us in guiding how to go through in Ethiopian context, particularly in identifying the study participants, in whom to engage in our research, particularly study participants. And another thing is, as I mentioned, during my visit in Dublin, we had a time with Dr. Cleona just to contextualize the approaches, that CBPR approach, and how we define the community, we define the stakeholders, and we try to initially draft the tools for healthcare providers and that of people with amputation. Then we have, as you know, we have regular meetings every Monday. Unless there is other overlapping duties, we do have weekly meetings every Monday. And then the main part of this project is the field work, like setting out the local research advisory committee. And the first thing that we did is identifying the members that particularly relate with our project. And we have conducted the first round of the meeting. Then we have a pre-test and actual study, and we have a translation, transcription, review of some transcripts, and getting familiarized with the data. So I do have some detailed presentation on that. This some photos from the brainstorming session that we had during my stay in UCD in Dublin, and we try to define the community and the stakeholders as well, for healthcare workers as well as people with amputation. While we are defining the community for this project, the community are people with amputation, so both those who already access the service and who have never accessed the service. And we decide to consider only those women or men with amputation, particularly lower limb amputation, rather than the upper limb. This is it could be both or the single lower limb amputation, and we will access them through those who are currently on admission. We do have hospitals here in Walaita, Ethiopia. So it's the Walaita Sodo Comprehensive Specialized Hospital and Sodo Christian Hospital. We will have those cases from there, and those previously admitted. Initially, we planned to make 5 years back free of amputation, but it's very difficult to identify people with amputation, particularly women, and we decided to go back 10 years, and so January 2030 to June 2020. Again, the same true for armament, early and the late stage of people with amputations, and those who have never acted the rehabilitation service. But we decide to be that steady participants should be varied, a variety of patients with, or variety of amputees. And we also have a plan to interview caregivers or family members, and others are the stakeholders. They have been take part in their local research advisory committee as a member. Then we have also defined the healthcare workers for our Ethiopian context. So we do have physiotherapists who are working in the hospital setup and the rehab setup, orthopedic technicians, and senior clinicians like surgeons, orthopedic surgeons, nurses or physicians who have been working in rehab center or physiotherapy center. And we do also have community-based rehab workers. So social workers will also be interviewed, and psychosocial support staff who are in the rehab centers will be interviewed for perspective of healthcare workers and community leaders. We also define the stakeholders, like they are from the local to policy level, international or national NGOs, Ministry of Health, National Disability Associations, local research advisory committees. These committee members are those people who have been working or leading the local offices, like those who are working in the health office, who are working in labor and social affairs, women, youth, and child offices, and those who are working in local NGOs that are related with rehab services. So they are considered as our stakeholders as well as member for local research advisory committee. And for local research advisory committee, as I mentioned earlier, we do have two groups, in two settings, in Arbaminch and the Walaita. So these are to mean a kind of a bigger than a kind of county. To mean Walaita zone is a kind of county, Walaita County and the Gamo County. And we further grouped into women and the men. And the members has been nominated from each stakeholder or state participant with amputation. So we do have overall in two settings as small as 9 local state advisory committee that is further grouped into men and women. So the smaller local state advisory committee member are 3 for our case, and it is about 6 for men. But in total, 9 to 12 are the members of local state advisory committee. And in this committee, initially we reached out to stakeholders directly visiting to their office in person, and we explained the objective of the study. And then we request their consent, and they were happy to take part in this research. And later, we provide them with the letter that assure their committee membership. Then based on that, we invite them for the first round of the meeting. And in that meeting, what we did is that just we explained the objective of the studies and the project, and we just request them to comment on the objective of the study in the first place. And we have details of the minutes, but one thing that I want to share in this meeting is that initially they commented us it would have been good to start this with from the very beginning with them, but we the middle we brought the objective, and they have been very happy with that objective. Then we also asked what to ask the people with amputation and we also request how to access those people. They guide us on how to reach out people with amputation as well as those who are never have been accessed the service. So based on that local research advisory committee, we revised the drafted tools, and we also redesigned the way that we reach out those study participants. These are some pictures from the workshop. The picture in the above is the meeting with the local research advisory committee. And in this committee, we do have organizations, people who represent from Women Disability Office, amputee, or the women with amputation. And we do also have this care list from the Women, Youth and the Child Office that are in line with ensuring the utilization of the service. So, and the lower picture indicates some members from different offices, like the first is the local labor and the social affairs office, local NGO project manager, health office that ensuring access of the service, religious leader, and main representative from the disability association, men with amputation, and this is the research assistant. So these are the pictures for men and the women local research advisory committee. Then this is from Arbaminch, a picture from Arbaminch. These are members of local research advisory committee in Arbaminch. We do have a woman with amputation, women who have been working in labor and social affairs. This woman is from the special needs officer at the Arbaminch University. She's from the community-based rehabilitation service coordinator. So in our project, we initially ensured the representation of the offices who are part of this study. And for this study participants, I think I have gone through with all these things. For our study, we interviewed orthopedic surgeons, physiotherapists, men and women orthopedic technicians, and CBPR. We not yet, we interviewed also CBPR workers in Arbaminch, yet to be interviewed for Walaita, and we not yet started the interview with people with amputation. This is the photo from workshop in UCD. During my stay in UCD, we had a workshop that I already presented previously. And this is the workshop in Walaita that we had, and we had a good workshop in Walaita area, and they helped us to directing us how to run the project in Ethiopia. And this is the training of research assistants that I early introduced with you. And these are the core research team has filed providing the key remarks and training the research assistants. So that the fieldwork update, I'm going to finalize. The final work is that for Walaita and for Arbaminch, for two settings, our plan is to conduct 44 interviews with people with amputation and with healthcare workers. And we started the interviewing with healthcare workers, and we, from the 22 plan to interview healthcare workers, we already interviewed 18 interviews and we transcribed 18. So we left with 4 interviews with healthcare workers. And we are also reviewing the transcripts, we commenting with the transcripts. So we already gone through half a while on reviewing and getting familiarized with those transcripts. So the challenges, somehow similar with the Cambodia, particularly related to accessing those people with amputation who never have been accessed. We noticed this thing during our pretest. We had conduct the pretest, and during that time it is very difficult, particularly to access a woman who have never accessed the service. And another is related with my stay during Dublin It's very short time, and in Ethiopia it's very difficult to get physiotherapists. They are very small in number. Even we didn't include in the as a member for local state advisory committee because of their number, and we use them for the pretest and for actual study. So this challenge. Another challenge is not having a woman healthcare workers. We don't have a single orthopedic surgeon woman. We only have one woman physiotherapist in southern part, and the rest are the men. And particularly during our study, we had difficulty to access clinicians. They have a lot of time. They appointed our research assistants, and they had emergency calls, and they are very busy with, and they have a difficulty to keep their promise, and we have the challenge on accessing them. Finally, we have been successful in accessing all of them, but it's very difficult to access them, particularly if they're being busy. And I think this is obvious, like the inflation. Next plan, project timeline, and now we are in December, and December to January, our plan is to conduct a study with people with amputation. So we do have women research assistants, so they will engage on that. And the finalizing data collection, particularly we left with 4 interviews with healthcare workers, and we never have started. We haven't started people with amputation, and we will finalize this month. And we will continue with transcribing and translating and getting familiarized with the data. On late January, we will have a plan to conduct a local advisory committee meeting for review of early stage of results. Then in February to March, we will start analysis and write-up. And April to December, we will produce the manuscripts, dissemination workshops, and if possible, as you know, the CBPR approach is ensuring long-term commitment, and hopefully following the findings, there will be implementation, and we can finally ensure the real CBPR approach. And this all, thank you. I would like to acknowledge we already initially acknowledged the Swedish Research Council and the deputies of taxpayers of the Swedish people. We acknowledge our president is always on board in supporting this project. Our study participants, particularly health workers and local state advisory committees, officials, and particularly this WOSU workshop participants. And thank you very much.
Thank you so much, Ricardo. This was a great insight into the project, the stages, the activities, the challenges. Absolutely great to see. And now we really have an overview over both projects, and we can actually, we are, as I said before, we are ahead of time, but that gives us enough time for the discussion. So I will share my screen again to enter into our last part, which is actually your part, dear audience. And I will, yeah, do you see the full screen, right? Not presentation, but perfect. So we are now in the Q&A discussion, and this is also where I would like to hand over to Klina, who is going to lead that session. I will go to one more slide, and now please, Klina, the floor is yours.
Yeah, great and fantastic. Now we might stop the recording now, if that's all right, just to allow full and free discussion, if that's okay. Yeah.